am Dr. Indira Maisnam. I am a consultant endocrinologist based in Kolkata. So today I have come to for a program in SpeedCon in Delhi, SpeedCon 2020, and where I was involved in a debate regarding not too recent 2018 guidelines of the ACP, that means the American College of Physicians, which tells us that in most patients with diabetes, the target HbA1c or the glycosylated hemoglobin A1c should be 7 to 8%. That's what they have said, and I actually spoke against the motion. So throughout, for many decades now, 2 decades let's say, we have had evidence that a HbA1c or a glycosylated hemoglobin of less than 7% is what is ideal for most patients with diabetes. Why did we come to this HbA1c of less than 7% as our target? Is based on very important studies like the UKPDS study, which took place many years back, and it was a long-term study where it was found that in patients with type 2 diabetes, when you treat patients to an HbA1c of less than 7%, then there was a decrease in the microvascular complications of diabetes. And there was a trend towards a decrease in the macrovascular complications of diabetes. Now, these UKPDS people, the population, were again followed up for many more years, and which is known as the UKPDS follow-up study. And here it was found that in patients who are assigned to good glycemic control, that is to an HbA1c of less than 7%, even 10 years after the study ended, the benefits were still seen, and at this time there was a decrease not only in the microvascular complications but also the macrovascular complications, like let's say atherosclerotic cardiovascular disease, all-cause mortality. So this tells us that in patients with type 2 diabetes, especially in the early years, if we give them good glycemic control of an HbA1c less than 7%, then it is a good investment for the health of the individual, in the sense that it would decrease immediately over the short term, decrease the microvascular complications like retinopathy, nephropathy, neuropathy, but over the long term would also continue to decrease the microvascular complications, but would also decrease the macrovascular complications. So similar study was also conducted in the diabetes, which was known as the DCCT study, and the follow-up is known as the DCCT EDIC study, which also gave the same result, that is, yes, in the early years it would decrease the microvascular complications, but over the long term also you have some macrovascular benefit. So when the ACP came with the guidelines that it should be 7 to 8%, the target, it was out of it like a ball from the blue. Why did it happen? So ACP also considered some other trials known as the ADVANCE trial, the VADT and ACCORD trial, where in these trials, so to tell specifically this ADVANCE, ACCORD or VADT, in these trials the study group or the population which was studied were much older than in the UKPDS. They also had longer duration of diabetes, and they had established cardiovascular disease. Now, in these trials, it was seen that there was a decrease in the microvascular complications, but for the macrovascular complications, they were short-term. It was a short study, and the macrovascular benefits were not seen. Also, in one study known as the ACCORD, because of the design of the study, or because of how the HbA1c was brought down, rather than the target HbA1c, there was increased mortality or death. So as a result of it, the ACP came down with this target of 7 to 8%, but that is not the way to look to. What we need to understand is that since throughout this so many years, we have understood that good glycemic control improves cardiovascular outcomes, good glycemic control prevents microvascular complications, and over the long term also improves cardiovascular outcomes. We need to consider this, and we need to individualize our targets. So let's say if it's somebody, a young person, or even if the person is not young, the person has a very long life expectancy. In that case, we would target an HbA1c of definitely less than 7%, so that the person would reap the benefits of a good glycemic control regarding the prevention of micro and over the long-term macrovascular complications also. But obviously, if the person is an older person, has many comorbid conditions and has a shorter life expectancy, in that case, we would not make such a huge target, such a target of, let's say, less than 7%. We would relax our targets, maybe 8, sometimes even 8.5%. And we should also remember that by the time the UKPDS was published, or for that matter, when the Accord, the VADT, and the Advance were published, we did not have so many anti-diabetic drugs like we have today. What the UKPDS found out was that the lower the blood glucose or the HbA1c, the lower it is, the better it is to prevent complications. But the problem with the lowering the blood glucose at that time was the fear of hypoglycemia, because at that time anti-diabetic drugs were known as oral and hypoglycemic agents. In fact, nowadays we don't use the term hypoglycemic agents, we use the term anti-diabetic agents or anti-hyperglycemic agents, because of the fact that the newer drugs, whether it is the gliflozins, whether it is the gliptins and the GLP-1 receptor agonists, they do not cause hypoglycemia. In fact, they just decrease the blood glucose that is raised, but they by themselves do not cause hypoglycemia, and also they are weight neutral or cause weight loss. So we have a large number of drugs which can give good glycemic benefit, at the same time do not cause the feared complications of anti-diabetic agents, that is hypoglycemia and weight gain. And therefore, in today's time, when we have a lot of agents, when we have evidence that HbA1c less than 7% is beneficial for somebody who has a long life expectancy, in those individuals, definitely we should target an HbA1c of less than 7%. In fact, we can get the HbA1c less than 6.5% without causing undue problem to the patient in the form of hypoglycemia or others, then we can in fact even lower it in, let's say, somebody in his 30s or early 40s. So in India, people are developing diabetes at a very young age, and therefore we see that the exposure, the overall exposure to diabetes is decades, and we need to protect the organs and the vasculature of this individual from the complications. And if we look from the cost perspective, it may seem that somebody who is being given a number of drugs so as to prevent the rise in HbA1c or the diabetes complication, it seems that it is an expensive affair. But if we look at the overall context of expenses, and if we extrapolate the data or the the expenditure, we see that it is not only cost effective, but it is also cost saving. Because if the person, so it is like a small insurance we pay, let's say, for our good health, we can take it in that way. Because for somebody who has a good glycemic control, not only glycemic control, but who has also control of blood pressure, lipids, stop smoking, and all these things, in all these individuals, the chances of a diabetes complications are much reduced. And therefore, investing in the cost for some good diabetes care, whether in the form of lifestyle, whether in the form of pharmacotherapy, will actually decrease the diabetes expenditure, diabetes related expenditure in the future. And therefore, it is a long-term investment, which I would say is more than cost effective. Cost effective means you get the same return for the amount of money that you have invested. It is cost saving, that means you get more returns, because it is health saving, and in that matter it is life saving. And therefore, in the times we live in today, where diabetes is diagnosed at a much younger age, where we have a lot of anti-hyperglycemic agents that do not cause hypoglycemia or weight gain, and because of the evidences we have had from the UKPDS and the recent trials, what we need to understand is that in most of the patients with diabetes, we would target an HbA1c of less than 7%. But then again, each and every guideline says that we have to individualize our patient, and therefore it depends on who our patient is. So if our patient is an elderly gentleman who has severe comorbidities in the form of, let's say, a chronic kidney disease, chronic liver disease, or atherosclerotic cardiovascular disease, in those individuals, our targets will be higher, and we will, in fact, in somebody with an end-of-life care, our target would be just to prevent asymptomatic hyperglycemia. Whereas in younger individuals, it's not rare for us to find teenagers who are having type 2 diabetes today. In those patients, because the exposure to hyperglycemia and other comorbidities that are associated with diabetes is so high, in these individuals, we will have an individualized target. And I would like to end by saying that diabetes treatment is not only about glycemic target, it is a holistic approach where we take into account the patient's lifestyle, the patient's, yes, and for that matter, the family, the society has to support the patient's control of not only glucose but also other cardiovascular risks, whether it is a form of hypertension, whether it is a form of dyslipidemia, whether it is in the form of smoking. All this should be controlled, and a holistic approach is the most important thing for diabetes care. And here the most so it is a multidisciplinary and a holistic approach where the center point or the center of the care is always the patient. Thank you.